So very good evening everyone. A very good evening to all of you, and let me know quickly in the chat box if I'm audible and visible, and we'll quickly start the session. Welcome to this psychiatry session of the NEET PG PYQ challenge, which is going on at the PrepLadder app, and really happy to see all of you, and I hope the preparation is really going good for the NEET PG exam. And when we talk about this session, in this session we are going to discuss the important PYQs of the NEET PG exam. And what I've done is we have taken the last 7 years of the MCQs. So we're going to discuss those MCQs, and what I'm going to do is I'm not going to discuss them year wise, we're going to discuss them topic wise. So that in this video we're going to discuss all those important PYQs, and this would become your one go-to video whenever you are seeing the PYQs, you are analyzing the PYQs. So welcome all of you in the session. And if you see the trend of psychiatry MCQs over the past 7 years, you would see that if I see the average around, again I'm expecting around 6 to 8 MCQs also this time in the NEET PG exam. And if they are asking more of integrated question, maybe you may get more of the questions from psychiatry, because as we know that a lot of integration is again going on in the psychiatry. So nowadays you'll see the trend is more towards the clinical vignettes. You'll see more of clinical question. In fact, I always say in the session, in the classes also now, that nowadays you'll see a lot of two-layered questions. Now when I say two-layered questions, but I mean that you'll see in the question, first of all they'll give you a clinical picture, they'll not tell you the diagnosis. You have to make an inference that what could be the diagnosis, and then accordingly they will ask some question maybe related to management. So it's very important whenever you are revising and whenever you're practicing MCQs also, now even if they're asking one question, just try to understand the entire clinical scenario. And as we've been discussing that yes, integration is occurring, and you'll see a lot of integration in psychopharmacology. Of course, you'll see so many questions of psychiatry and pharmacology you'll see in the exam, and also forensic psychiatry, many questions you will see. And some integration would also be there in other subjects, like in pathology, there will be images, microscopic finding like in dementia, even some findings from physiology like sleep physiology, and some of the other clinical subjects also you may see some integration. Now very important, I want all of you to understand that you will see many questions from emergency presentations. Now it could be a substance emergency, it could be a drug emergency, overdose, and many questions you will see from the emergency presentation again becomes very important. See, previously if you see, images are not much asked, and in fact we'll discuss one image of sleep EEG was asked, and I'm sure all of us now are thinking of, sir, what about videos? Now don't worry about the videos. Wherever relevant, wherever possible they could ask videos, we'll discuss those points also. But again, the concept becomes very similar. You have to understand the concept, and if you know the concept, even if it's a video based question, I'm sure all of us can answer that question. So let's quickly begin this session. But let's start with the first question. See, so we'll start from the basics. A patient with schizophrenia presents to the OPD. Which of the following is included in formal thought disorder? So again, they're asking questions from the basics as well. So can you tell me what is the right answer? So in MSc, we always talk about now that the thought is divided into 4 categories: flow, content, form, possession. So tell me what is the right answer? Very good. So we know in flow, we discuss very important categories such as flight of ideas, very important. There is circumstantiality we discuss. And also we talk about very important is perseveration. Now this perseveration again is very important, but please, whenever you're reading now, try to read some of these important points. In content, all of us know in content there is delusion, a very important topic. Again, sometimes you'll see directly, indirectly question being asked from delusion. And as you're all saying correctly, yes, we know that derailment is a disorder of form. It's a formal thought disorder. Can you tell me where would you place obsession, beta? Very good. See, where would you place obsession? If I ask you, obsession is an abnormality. See, we discuss in the classes now, obsession is rhyming with possession also. For all practical purposes, remember, obsession is an abnormality of possession. So they may give you a clinical scenario also, like they'll give you a case of OCD, and they may just ask you, it's an abnormality of flow, content, form, and possession. So all of you are correct. It is derailment. And what is derailment? As the name suggests, we know derailment ka matlab kya hai, beta? Derailment means the person is on track for some time and suddenly derails from that topic. Suddenly you'll see when the person is speaking, suddenly he changes the topic, and that topic is not related with what he was talking previously. So this is derailment. Also, you will see sometimes nowadays clinical question would be asked that a person is saying this. So they'll give you a speech sample and you have to identify that what phenomena is seen. So very good. Now let's see this question. In fact, this question was asked in 2025. That is why I'm saying you'll see many clinical questions like these. A young male patient comes to the psychiatry OPD and he says when he sees the bird's wing flapping or flying outside, he believes that these movements of the bird is telling him to move in a different direction and he do it. He thinks that it is the God's way of telling him through the birds to keep him safe. What is the likely phenomena? Very good. Now can you appreciate this question in fact has been asked from the SFRS. When you'll see nowadays, again I'm saying when you are revising schizophrenia, please revise history and please try to understand the clinical aspect as well. For example, in SFRS, we talk about this phenomena that is delusional perception. As the name suggests, the person gives a delusional meaning to a normal perception. Like in this case, he sees the birds flying. So it's a normal perception and he develops a delusional meaning to it. So this is delusional perception. Similarly, there is one more important phenomena. Can anybody tell me what is somatic passivity? Very good. What is somatic passivity? Again, just see the name. Somatic passivity, as the name suggests, the person is experiencing some bodily sensation. And I always say, in psychiatry, whenever they say passivity means it is controlled by an external agency. So person says that, sir, I am having pain in the abdomen. So it's a bodily sensation because of alien sending radio waves. So such kind of clinical question also may be asked from the history. In fact, if you appreciate in INI-CET also a question came from Bloyler's 4As. If you remember in Bloyler's 4As, we have talked about autism, autistic thinking. So question on autistic thinking has also been recently asked. So sometimes if they are asking question from the history, they may ask such clinical question. So please try to understand the concept rather than mugging up so that we can answer these questions. Very good. The answer is option A. Let's now go to the next question. So you will see many questions even from the management, and antipsychotic become a very important category of drug. But let's answer this question. Let me see if we can answer. A patient diagnosed with schizophrenia. So I'm also trying to highlight the keywords, the buzzwords, which when you're practicing MCQ is also giving GTs, try to identify these buzzwords. So schizophrenia is the diagnosis and patient is on haloperidol, thioridazine. But what are these category of drugs? Always, whenever you see drugs in the questions, when you're practicing now, always try to identify the category. So these are first generation antipsychotics. And you started, there was no response, you started on another drug, drug A, which has a side effect of hyperglycemia, dyslipidemia and excessive salivation. So I hope all of us are able to understand what is this phenomena. This is treatment resistant schizophrenia. That is no response. Patient is not showing response to at least 2 antipsychotics. So now which drug we are going to use? Very good. So the drug we are going to now use is clozapine. Very good. So clozapine again is a very important drug. Clozapine is a second generation antipsychotic, but also remember some serious side effects of clozapine, which we have been remembering with this mnemonic SAM, and A is very, very important, A granulocytosis. So let me just give you a clinical picture if they want to ask question from this. A person on clozapine comes to us with, there is sore throat, there is fever, there is tachycardia. So they are giving you some infection and the person is on clozapine. So what you now going to do, you may suspect it could be because of A granulocytosis. Check the blood counts. If it is reduced, then we have to stop that drug. Is it clear? Person can have seizure, even myocarditis. This clinical picture may be asked. That person on clozapine comes to us with chest pain, abnormal ECG. So then again, I'm suspecting myocarditis. So these are some important points. But also tell me one practical method. We have discussed now. Patient is having excessive salivation. Patient comes in the ward in the morning that my pillow is all wet because of excessive salivation. It occurs because of decrease of swallowing. So can anybody tell me what is the first practical method, what we will do? First practical method we'll do, what we can do is we can ask the person to put a towel over the pillow. Put a towel over the pillow. So this is the first practical step. You can ask the patient to help the patient. Okay. Yes. And why, can anybody tell me why these metabolic side effects are occurring? Metabolic side effects also. Remember the mechanism of these side effects also. Why metabolic side effects are occurring? Remember, we have discussed it occurs because of blockage of 5-HT2C. 5-HT2C antagonism. So they may also ask you the mechanism. So please remember this. Let's now discuss the next question. Let's see this question, A patient diagnosed with schizophrenia, again try to see the scenario, the diagnosis is schizophrenia and the patient is on triflupromazine and he developed Parkinson-like symptoms. So patient is on first generation antipsychotic and patient develops Parkinson-like symptoms. So can anybody tell me what we are suspecting? Now this is a very important topic, but a very important topic which can come in the exam, and also this is one of the topics which can be also asked as a video based question. So they may give you in the video some abnormal movements and they may ask you that what the person is having. So we are talking about EPS. Very good. This is extrapyramidal symptom. This is drug induced Parkinsonism or pseudo Parkinsonism, and the management we know it is trihexyphenidyl. So in fact just have an idea, but let's see this table again. Very important. So we have remembered some of these important EPS. Now why EPS is occurring, can anybody tell me? Very important. Tell me why EPS are occurring. They may just ask you in this question, beta, they may just ask you what is the reason. EPS occurs because of D2 antagonism. Now we know there are different dopamine pathways, and two important dopamine pathways we have learned which are associated with the side effect. So if dopamine is blocked in the nigrostriatal pathway, very important, in the nigrostriatal pathway, beta, that leads to EPS. So they may just ask you the mechanism of these side effects. So EPS we have learned with this mnemonic DP at night. A patient comes to us on antipsychotic. Please hear everyone, there is sudden twisting of neck, there is torticollis, or the person complains that my eyes are uprolled upwards. What we are suspecting? You are suspecting acute dystonia. Again, treatment is anticholinergic drug. We can give parenteral drugs like promethazine, benztropine. Person is having, like in this video you can see patient has tremors, rigidity, bradykinesia. We are suspecting drug induced Parkinsonism. Again, we can give anticholinergic drug. There we can give oral drugs also like trihexyphenidyl. Also remember, this question has been asked as an image based question in some other exam, that a person is on antipsychotic and presents to us with perioral tremors like rabbits. Now there is perioral tremors like this, but this is rabbit syndrome. Again, it is a manifestation of drug induced Parkinsonism which occurs after long term treatment with antipsychotic. Next is again very important, akathisia. Next time they may just tell you, like you can see the person is not able to stay still. Even when the person is sitting, the person is continuously moving, or the person is pacing around in the ward, he is on antipsychotic. Now what you're suspecting? We're suspecting akathisia. Patient is restless from inside also, and when you're seeing the patient objectively also, patient is very restless, and the drug of choice is beta blocker like propranolol. Tardive dyskinesia, again you may be shown videos like there is chewing movement like this, tongue protrusion movements, or hand में coriform movements like this, or pelvic thrusting movement like this. Very good. This again occurs because of long-term use of antipsychotic because of D2. Very good. Super sensitivity of the receptors. Because of this long-term use, say there is super sensitivity of the D2 receptors which can lead to tardive dyskinesia. And the drugs we can use is valbenazine, deutetrabenazine, which are VMAT2 inhibitors. Another important presentation you may get is this, but in emergencies now you can get such presentations. Patient is on antipsychotic, they may just give you a name, they may tell you the diagnosis, and person comes to us with high temperature, increase in the CPK, muscle rigidity. There may be other symptoms like increased blood pressure, confusion, sweating, increase in TLC count, LFTs are deranged. What we are suspecting? Very important, NMS, and the first step would be to stop antipsychotic. And if they ask you drug of choice, then we can use drugs like dantrolene. Even dopamine agonists like amantadine, bromocriptine can be used. So I'm trying to give you the presentation also, so that if such question come, try to identify the keywords, see the clinical scenario, and then answer the question. Let's see another question. In fact, in the last exam, beta, see, they have asked question again from EPS. So EPS becomes very important. Let's answer this question. A patient with schizophrenia is responding well to haloperidol for 2 years. So haloperidol you have identified, it is first generation antipsychotic. Right, now the person presents with, see the presentation, there is orofacial dyskinesia, coriform, tick-like movements, possible dystonia. So if you see the predominant clinical picture, beta, can I say what is this? Person is having orofacial dyskinesia, there is coriform, tick-like movements are there. So can anybody tell me what is the right answer? It is not akathisia. We have discussed it is not akathisia, it is not acute dystonia, and also that is also not the management. They are not mentioning just oral tremor. So here what is the right answer? The right answer is it is tardive dyskinesia, and the drug which can be used is valbenazine. So see, EPS is a very important topic. Now psychopharmacology mein EPS becomes a very important topic. Let's see one more question. This in fact is a Older question in 2019 they had asked this question. Let me see if we can answer this question. Which of the following is not a risk factor for delusional disorder? So we have been discussing this, since it is asked also previously. We have been talking about this. See, in schizophrenia, when we talk about prognostic factors, in schizophrenia we say late onset has good prognosis. But when we're talking about delusional disorder, very good. But please remember, early age of onset is not a risk factor. We say advanced age. Advanced age is a risk factor. So as the age increases, we say advanced age is a risk factor. Yes, social isolation is a risk factor. Recent immigration, sensory deprivation, patient has comorbid depression. Again, that also is a risk factor. So these are some risk factors for development of delusional disorder. And if I ask you, beta, what is delusional disorder? Can you tell me, from the symptoms, can you differentiate delusional disorder from schizophrenia? Can you differentiate clinically also? They may just also ask a clinical question. A patient is having, let us say, delusion of persecution, delusion of reference, delusion of infidelity. The patient is having these delusions, let us say, for 6 months. Tell me, diagnosis is schizophrenia or delusional disorder? Let me see if we can answer this question. A patient has delusion of persecution. Patient thinks people want to kill me, or people are talking about me, or my spouse is having an affair. Tell me, patient is having these symptoms, it is schizophrenia or delusional disorder? Please remember, when we are making the diagnosis of schizophrenia, that is why I want you to remember this. Schizophrenia may we say 2 or more symptoms should be there, beta. Now remember the 5 symptoms we have discussed with the mnemonic dhadkan. Na? So we are saying 2 or more symptoms for schizophrenia. Here patient is having only delusions. It may be 1 or it may be multiple delusion. So remember, if there are only delusions now, then my diagnosis would be delusional disorder. Very good. For schizophrenia, we have discussed now 5 may say at least two symptoms should be there, and at least one of the symptoms should be from first 3. First 3 mein kaun hai? Delusion, hallucination and disorganized speech. So please be very careful when you're making the diagnosis. Also, let me know if you can remember, can anybody tell me a very important bit of drug update we have discussed? So I'm going to discuss some newer drugs also, so that you have an idea how questions may be framed. Very good. Can anybody tell me about a drug starting with X, which has been approved for schizophrenia, which has a different mechanism of action? Remember the name xanomeline. Also, what is the mechanism? From the name itself, we will remember it is one of the drugs which has a unique mechanism. It is a M1 M4 agonist. Remember this. Okay, so please remember some of the drug updates also which we have been discussing. I'll give you one more update. Very recently one more drug has been approved for ADHD. We'll discuss that when I'll talk about child psychiatry ka topic. So you can see how some of the questions from these topics of psychotic disorders have been asked. Let's now move to another very important topic, mood disorders. Especially you'll see questions have been asked on the specifier. So beta, let's see this question. Let me see if we can answer this question. A patient presents with low mood, decreased sleep, decreased appetite for 6 months, also having death wishes. He now has developed new symptom for the last 2 weeks in the form of voices telling him to die, along with persistence of previous symptoms. So already he's having depression. Now he's having some more symptoms. Very good. But what is the diagnosis? This again is a very important topic as we have been discussing on specifiers. So you may expect some questions on specifiers. And what is this specifier? Can I say predominantly patient is having symptoms of depression and now he has developed psychotic symptoms. Psychotic symptoms are delusions or hallucination patient has developed. My answer would be it is depression with psychotic symptom. And what is the treatment? What is the treatment here? Along with antidepressant, we can also give antipsychotic. Schizophrenia, we know. What are the symptoms? Now, what is schizoaffective disorder? Anybody? Can you appreciate from the name schizoaffective disorder? Symptoms of both schizophrenia wale symptoms and affective disorder wale symptoms. Both symptoms present together for more than 50% of the time of the illness. So, both symptoms are present together. And DSM-5 also says, but what is the catch point here? DSM-5 also says that during that entire illness, there should be at least 2 weeks when patient has only delusions, hallucination and no mood symptoms. While in this scenario, can you appreciate throughout the course of illness, patient is having depressive symptoms. So primary diagnosis is depression. Now we are going to add the specified depression with psychotic symptoms. Very good. Very good. Acha, tell me this point also. Let me see if you can answer this question. Now, many of us, when we are practicing MCQs, we will see that, sir, depression and negative symptoms of schizophrenia, may appear very similar. Like, what are the negative symptoms of schizophrenia? Anhedonia, interest is reduced. There is avolition, decreased motivation. There is affective flattening. There is alogia, speaking very less. And patient may be having asociality, social withdrawal. तो आप बोलोगे सर ये symptoms भी depression जैसे लगते हैं. Can anybody tell me clinically how will you differentiate this? These 2 points very important. But I always say na, whenever you are stuck na, always go back to the basics. Can anybody tell me बेटा देखो duration में schizophrenia का minimum duration 6 months है ना. Depression symptoms let me say कि 6 months हैं. तो duration will not be that important differentiating factor ना. ड्यूरेशन में तो स्टक हो जाओगे क्योंकि डिप्रेशन में भी हम कह रहे हैं 6 मंथ्स है लेटर से, एंड स्किज़ोफ्रेनिया में तो वी नो 6 मंथ्स इज द मिनिमम ड्यूरेशन फॉर DSM-5 टू मेक अ डायग्नोसिस. इंपॉर्टेंट बट फ्रॉम नेगेटिव सिम्टम आई एम आस्किंग, हैलुसिनेशन है? यस, हैलुसिनेशन तो डिप्रेशन ही हो सकता है. दे आर साइकोटिक सिम्टम्स ना. वेरी गुड बेटा. आई ऑलवेज से ना, सी द बेसिक्स. डिप्रेशन इज अ मूड डिसऑर्डर. हियर द पर्सन विल रिपोर्ट ऑफ लो मूड. In a patient with negative symptoms schizophrenia may say my mood is fine, there is no problem in my mood. Very important, remember depression may you will see that there is a low mood. So let's quickly see these specifiers. I hope all of us have revised these specifiers now. Postpartum depression I am going to discuss. Melancholic depression. What is melancholic depression? It is a more severe form of depression. Patient has more severe form of symptoms of depression. We'll discuss that in one of the MCQs which was asked, beta. What is atypical depression? Remember that mnemonic we have discussed now. For atypical depression, my will high. Patient has mood reactivity. Positive event में patient का mood cheerful हो जाता है. Weight gain है. Interpersonal rejection sensitivity is there. Laden paralysis है. And H for remember hypersomnia. So patient को इस तरह के symptoms हैं. It is atypical depression. Patient says, sir, my depression symptoms are occurring every time in winters in a particular season. Season go, symptoms go. Then I'm talking about seasonal pattern. And recurrent means patient says my episodes are occurring again and again. So then we are adding the specifier recurrent depression. Please be very careful beta with these specifiers. Let's see this question. You will see many questions from specifiers. A 25-year-old female would get anxious mood swings with occasional sleep disturbance, crying episodes after the birth of the child, and got referred from obstetrics department after 5 days post delivery. Within few days after delivery, person comes with such mild symptoms. What diagnosis you're going to make here? It is postpartum blues. Very good and very important to remember. How to differentiate beta? Postpartum blues, the symptoms may be mild and within few days of delivery you will see the symptoms are present. Postpartum depression, when we are saying symptoms of depression, so it is qualifying that criteria of size caps have occurred within 6 weeks of delivery. And symptom wise na, symptoms such as suicidal thoughts, anhedonia, guilt, these symptoms again are more suggestive of depression than postpartum blues. Also we know a new class of drug, but can you name some important drugs which have been approved especially for postpartum depression? Do you remember we have talked about these category na, GABA A modulators. We have talked about these 2 drugs, important drugs. What are the 2 drugs beta? Very good. Brexanolone and zuranolone. Very good. Please remember we have talked about brexanolone and zuranolone. And especially remember brexanolone, it's a IV drug, zuranolone, it's a oral drug. Okay, so we are also revising some of these names so that if such newer drugs come, we are able to answer. Very good. Now let's see this question. So it's a very simple short question. Which of the following denotes intense depression and feeling of misery, feeling of guilt? Person is, it appears person is severely depressed. And a very interesting question, beta. This question was asked in 2019. Now, can you appreciate in this question they have mentioned both major depression also and melancholia also, beta. So please see the question carefully. They're trying to ask you, trying to give you a more severe form of depression. Here the answer is melancholic depression or melancholia. Yes, sure beta. These questions would be useful for all different exams, right? So melancholia. Now what is melancholia or melancholic depression? Here there is more severe form of depression. Now we have talked about this now with the mnemonic melancholic depression. We'll discuss M for melancholic, E for a lot of E's and L wale symptom. Remember? L for, we have discussed loss of reactivity is there, loss of reactivity, there is loss of interest in all the activities, and a lot of E wale symptoms. Remember, early morning awakening, patient wakes up 2 hours before the usual time. The person is having excessive guilt, there is excessive guilt. Patient का जो mood है is very severely sad. Patient reports of empty mood. Patient is also eating very less. So there is decrease in weight. So a lot of these symptoms, they are pointing towards melancholic depression. I hope this is clear now. So please be very careful when you are asked question on the specifier. Now also you will see a lot of questions. See, depression में diagnosis, specifier is a very important topic, and also the management. In the management, again, as we discussed, antipsychotics are important, but also another important category is antidepressants. So patient diagnosed with depression was on antidepressants. So these are some important buzzwords. Presence in the emergency with altered sensorium, hypotension, ECG showing QRS complexes, which is the most appropriate treatment. Okay, tell me. But see, why not? We were discussing na. Dekho, D would be also answer, but here a more specific answer they are asking na. It's a major depressive disorder, you can say, but again they are asking you. See, they've just added these few words, and you have to tell that what you're thinking. And in the option, melancholy is there. So they are, actually asking you which of the specifier maybe in the patient, right? So yes, D is also correct. If A was not given, then you could go with D. So answer this question, beta. Can you appreciate patient is on an antidepressant and you see a lot of CNS, CVS and ANS wale symptoms? Remember in TCA toxicity we discussed. In CNS we discussed the 3 C's na. There is convulsion, coma, patient may have confusion. CVS may be discussed arrhythmias, there may be increase in the QRS complex. Now you tell me in ANS what kind of symptom you may get. Sometimes they've asked question from the symptoms also. Tell me, there is hyperthermia, and when you look into the eyes of the patient, beta, can anybody tell me what finding you will get? What will be the finding when you see the eyes of the patient? Very, very important. Let me see if you can answer this. What will you see? Very important is, remember, mydriasis may be seen. Mydriasis. Okay. Please remember this. So in TCA toxicity, there is mydriasis, and how do we manage? Patient may develop acidosis, and patient, it is managed by giving sodium bicarbonate. In fact, beta, these are some of the emergencies I've been talking about. See, they may give you a clinical picture of NMS. Somewhere in the question, they are telling you patient is on a D2 antagonist. This TCA toxicity, like we have discussed, patient may develop serotonin syndrome. Serotonin syndrome means they will give you clinical picture ki patient is on serotonergic drugs. For example, in the management of depression, patient is having multiple such serotonergic drug. TCA toxicity, lithium toxicity is also very important, and also in the substance wala category na, we'll discuss like delirium tremens, opioid intoxication, cocaine intoxication. Such intoxications may also be asked. So the answer here is beta option number D. Let's see this question. In fact, another question on such emergency presentation. Let us see if we can answer this. A patient on SSRI sertraline was also added amitriptyline. So what is amitriptyline? It is a tricyclic antidepressant. So another antidepressant is added, and they mentioned that patient has developed serotonin toxicity or serotonin syndrome. So patient may have GI symptoms like diarrhea, there may be CNS symptoms, maybe their clonus may be there. So many symptoms may be there. And tell me what is the likely treatment here. So what is the treatment? We can give serotonin 5-HT2 antagonist cyproheptadine. Supportive care is done, and we can use drugs like cyproheptadine. So try to see this clinical picture, and then we are going to answer accordingly. I hope this is clear to everyone now. So the topic of depression and antidepressant is a very important topic. Also tell me, let us say a patient is pregnant and the patient has developed depression. Along with this, there is suicidal thoughts. Patient is having a very high risk of suicidal thoughts. Patient is having suicidal thoughts, and patient may even be trying to attempt. So there is, again, it's an emergency. Can you tell me how will we manage for your MCQs? What is the treatment, preferred treatment when such MCQs are asked? Send the patient home with drugs, antidepressants start karo and send the patient home. Start, OPD treatment with therapy, or admit the patient. What should we do here? What should we do here, beta? What can we do? See, you can say, sir, we can hospitalize the patient. Hospitalization is required, yes, because we have to take care of the patient. We have to see if the risk is very high. So we have to keep the patient in a safer environment. Also for MCQs, better see, if I don't add pregnancy, if I ask you depression with suicidal thoughts, what is the preferred treatment for your MCQs, better? ECT has shown good results. But even if pregnancy is there and the risk is high, again ECT is not a contraindication in pregnancy. In pregnancy also ECT can be given. So the point I'm making is that depression plus suicidal thoughts for an MCQs, one of the treatment modalities is ECT. I hope this is clear. Admit is important, hospitalization, yes, correct. Now let's discuss some questions on bipolar disorder. So in mood disorder, one is depression. Now we are talking about bipolar disorder. Let's see this question. A very interesting question was asked. And you will see sometimes there are two options now which sometimes can confuse us. But examiner will give you something to help you to reach to the diagnosis. See, 16-year-old female patient presents with talkativeness, over familiarity, flight of ideas, elevated mood, increased sexual desire, pseudo hallucination. These symptoms are present. You have to tell me, beta, this is very good. So we are thinking it is mania or hypomania. Tell me why you are thinking of mania, not hypomania. One important point. Very good. All of you are remembering. Yes, the mnemonic we have discussed, me dig fast. So we know to make a diagnosis of mania, the symptom duration is 7 days, and for hypomania it is at least 4 days. Better tell me why you are saying very good, because you will say, sir, flight of ideas is usually seen in mania and less likely in hypomania. In fact, remember, in hypomania you will not see psychotic symptoms. So if psychotic symptoms they are giving you, then I'm thinking of mania with psychotic symptom. Also, there is no need for hospitalization. See, suppose if the patient has 5 days ke symptoms, so 5 days I'm not thinking of mania, but somewhere they say that patient is hospitalized. So then again, I'm thinking of mania, not hypomania. And also generally flight of ideas is more likely to be seen in mania than hypomania. So again, these are important pointers, very important. Is it clear to everyone? So let's see one more question. So also question on management. In fact, this is a very interesting question they've asked in the exams. Let us see if we can answer this question. A 30-year-old female patient presents to us with a diagnosis of depression, and she was started on imipramine. What is imipramine? Anybody can tell me? Imipramine is what? You'll say, sir, it's an antidepressant, it's a TCA. The treatment was given for 2 weeks. After that, the relatives noticed that the patient has developed now newer symptoms of excessive cheerfulness, excitement, wearing colorful clothes, making new plans, and increased talking. What is the next step in the management? Very good. Okay, what is the next step in the management? Better tell me. You will say, sir, first, see, this is the clinical scenario we're talking about. Depression tha, antidepressant humne diya. Now patient has developed manic, hypomanic wale symptom. So first step, you will say, sir, we will discontinue imipramine, we will stop antidepressant. We have learned this now, because antidepressant are going to elevate the mood. Mood to already too much elevated hai. Now what you're going to do, beta, start antipsychotic या फिर sodium valproate. See, we have talked about this point now, that in a female in reproductive age group will try to avoid giving valproate. I'm not saying it is contraindicated, but we'll avoid because it can cause PCOD. Now, of course, there is a new name. PMOS is a new name. So we remember that yes, it can cause. So what we can give, beta, answer is option C. So in this one question, they have given two important concepts. So please see this. Also, can anybody tell me? Chalo, let me ask you this question also. If the question is of bipolar depression, beta. See, next time this question may be asked. If the question is on bipolar depression, what is bipolar depression? If I ask you, you will say, sir, bipolar depression means that patient right now is having a depressive episode, and in the past patient must have had an episode of mania or hypomania. Tabhi hum keh rahe na bipolar depression. Can anybody tell me one important point in the management of this episode in bipolar depression? We have discussed this point also. Tell me what is one key important concept. Should I give only antidepressant? Shall I give antidepressant alone? Tell me. We talked about this now. If I give antidepressant alone, patient may have risk of beta switch. So here the concept is don't give antidepressant alone. Okay, so next time they may just ask you this question. The patient has a depressive episode. Somewhere in the past he had a manic hypomanic episode, and now how you will manage this depressive episode? So one option they may just give you as an antidepressant. Please remember, if you're giving antidepressant, we can also add a drug like a mood stabilizer. Very good. I hope this is clear now. Bipolar 1, bipolar 2, all of us know na. Bipolar 1 is if a patient has at least one episode of mania, it is bipolar 1. Patient may have other episodes also like depression, hypomania, but ek bar mania, then I'm thinking of bipolar 1. And bipolar 2 disorder kya hota hai beta? If patient has episodes of depression and hypomania एंड नो मेनिया। ठीक है, तो आंसर इज बेटा, इस क्वेश्चन का आंसर है ऑप्शन सी। ओके बेटा, देखो थर्ड ट्राइमेस्टर में ना, बिफोर देखो, there may be, yes, you may be right that because of changes, physiological changes in pregnancy, we may require to increase the dose, but एक क्वेश्चन आया था INI-CET में ना, उसमें था कि पेशेंट इज स्टेबल। सो इफ द पेशेंट इज स्टेबल बेटा ऑन अ डोज ऑफ लिथियम इन प्रेगनेंसी इन थर्ड ट्राइमेस्टर, पेशेंट स्टेबल है तो वी आर गोइंग टू मॉनिटर। I will check the levels. So had there been the level had decreased or had there been symptom, then I could have thought of increasing the lithium dose. So first would be to monitor, but also we know that just before delivery we decrease the lithium because there may be risk of toxic to the baby. So there the answer was decrease. Okay, I hope this is clear to everyone now. Huh. Let's see this question now, but again this topic is an important topic, and you will see recently question again was asked from this topic. A 75-year-old female presents with difficulty doing activities of daily living. She is unable to remember things, so they are trying to tell you ki patient has developed some cognitive impairment. She also reports of seeing people and keeps staring empty spaces. So what is this? That is suggesting of visual hallucination. She also has motor features like bradykinesia, resting tremors, and also in the brain they are saying that the patient has Lewy body. So two important differential diagnoses of this condition is, one is Lewy body disease and another is Parkinson disease. So they have mentioned Parkinson disease in the question, but that is the answer. But suppose if both are given, the option, beta, can you tell me how will you differentiate if both are given? Very important. So this topic is very important, but please remember we've talked about this. Now overall the second most common cause of dementia is Lewy body disease. First most common cause we all of us know is Alzheimer's disease. And we remember the symptoms beta with this mnemonic na, CVMR, that is cognitive fluctuation, visual hallucination, motor features of Parkinsonism. Also remember this last potential new MCQ, REM sleep behavior disorder can also be there in the patient. So they may just give you this scenario that patient has REM sleep behavior disorder, which dementia we may be suspecting. We may be suspecting Lewy body disease. And there are also supportive features like Capgras syndrome is there. There is also increased risk of EPS. Such supportive features are also there. And Lewy bodies can be seen. So you may be given images also, but again pathology में ना you may be integrated with such images. Now when I'm asking बेटा, अगर दोनों ऑप्शन में दिया हुआ है कैसे डिफरेंशिएट करोगे बेटा? अगर दोनों ऑप्शन में दिया हुआ है, वी नो ना पार्किंसन डिजीज डिमेंशिया इज अ सबकॉर्टिकल डिमेंशिया. So you will see their motor symptom would begin first, followed by cognitive symptom. In fact, in the research criteria we take कि motor symptom शुरू होने से at least 1 year later the cognitive symptom would develop. While in Lewy body dementia we have discussed it is having mixed features, both cortex and subcortex are involved, so cognitive symptom would be there in the beginning plus minus motor symptoms. Motor symptoms may be there in the beginning or may occur later on. So clinically, if they ask you both options are given, then this is how clinically we can differentiate. I hope this is clear. This is a very, very important topic, but please remember this. Very good. Let's now see this question. See, this question was asked in 2019, and sometimes when such scales or such things are asked in psychiatry, I always say na, please see the name. Don't leave the question before just focusing on the terms which have been used and the options. Let's answer this question. Let's try to answer this question. Very good. So why you are saying confusion assessment method is used for delirium beta? Very good, because we've learned now कि confusion is seen in delirium. In fact, delirium में beta, what is the key point we have learned? That there is impairment. There is impairment of consciousness. So we have learned about this, that there is impairment of consciousness. And can anybody tell me the trick we have used to understand the points which may be given in the question telling us that there is impairment of consciousness? So let's quickly revise this. Tell me, A for patient may have altered sensorium. Somewhere they are telling you that there is altered sensorium. Or C for there is clouding of consciousness beta. What is D? Can anybody tell me what is D? D for disorientation. Somewhere in the question they are telling you कि patient is disoriented to time, place or person. Patient is in the hospital, he says I am at my home. Or they are telling that patient has confusion, person is confused about self, about others. So if any of these points given in the question, this is telling us that patient may have developed impairment of consciousness and we are thinking of delirium. I hope this is clear now. So please remember this. Let's now see this question. So now we are going to discuss better questions from the topic of neurotic disorders, and you will see neurotic disorders when we've talked about. First we'll discuss some questions on anxiety disorders. So let's see this question. This question you will see has been in fact repeated, at least a couple of times in the exams. Recently asked, a 18-year-old first year MBBS student reports of experiencing episodes of tightness sensation in chest, anxiety, feeling of impending doom lasting for 30-40 minutes. 4 to 5 episodes are occurring in the last 3-4 minutes. The student repeatedly came 3 times in the OPD with the same symptoms. Investigation mein they're telling you everything is normal, and then she was referred to the psychiatrist. Tell me what is the likely answer. Very good. The answer here is, it is panic disorder. But in fact we have talked about these anxiety disorders. I hope you remember when we discussed these anxiety disorders, we have divided them into 3 categories. One we have talked about is the panic disorder. Patient is having such episodes, of sudden intense anxiety with feeling of impending doom. Keyword, patient ko lag raha hai I am about to die, and in between the person becomes normal. Beta phobias mein, what all phobias we have discussed? Phobias ka matlab anxiety is there whenever there is a situation. Remember agoraphobia? Very good. We have discussed agoraphobia, we have talked about specific phobia and social phobia. And in GAD, can you appreciate, patient has, worries, persistent anxiety, and very important point to identify is excessive worries. So here the answer is, it is panic disorder. Okay, tell me what is the treatment of panic disorder, beta? We can use drugs like SSRI plus minus benzodiazepine. For short duration we can also give benzodiazepine. If they ask you for an acute attack, patient says, sir mujhe abhi panic attack ho raha hai, in that case preferred drug is benzodiazepine. But for the treatment, remember drug of choices for panic disorder, it is SSRI. We can give therapy like CBT. Tell me the treatment of choice, beta. Treatment of choice kya hoga? We have discussed drug of choice, therapy of choice. Treatment of choice is a combination. Combination has shown good results. Okay. I hope this is clear. Also in the phobias, beta, when we talk about agoraphobia, I hope all of us remember na, agoraphobia mein there are 5 situations. There is public transport, anxiety in open spaces, closed spaces, standing in a line or in crowded places, and alone outside of the home. If person has anxiety in at least 2 or more situations, beta, ye key point hai. If patient has anxiety in 2 or more situations, then we are thinking of agoraphobia. So agar patient ko sirf lift mein anxiety hai, then better answer would be specific phobia. I hope this is clear now. Then it is specific phobia. Let's see this question now. Again see, a very similar question now, similar clinical presentation. Kya answer hai beta isme? Brought with symptoms of anxiety, palpitation, sweating, breathlessness, chest pain, feeling she might have a heart attack, or feeling of impending doom is given. So again, the answer here is, again, it is panic disorder. So beta, these are very small but very important topics. Please revise them. Try to identify the clinical picture and see the options. You'll get to the right answer. Right? Now let's see this question. Now this is, again, you will see better last 2 years, especially 2024, 2025, you will see a lot of such clinical vignettes being given. Let's try to identify. First you have to tell me what is the right diagnosis in this condition. Beta, pehle diagnosis batana mujhe. Then you have to tell me what is the right answer. A 45-year-old female comes to the OPD with complaints of feeling tensed and having stomach upset with heartburn, dyspepsia and diarrhea. She reports of having these symptoms for many years. She also tells her family members are also usually tensed and nervous. So yes, there can be family history also of some of the psychiatric disorders. So you have to first tell me, beta, very good. Can you appreciate patient is continuously having a lot of nervousness, tensed feeling, there are worries. So this is what, along with this, yes, patient can also have somatic symptoms. Patient here is having GI symptoms. So what is the right answer? See, so hallucinations, beta, neologism, these we'll see in condition like schizophrenia, in psychotic disorders. What is idea of reference? Idea of reference, when we say delusion of reference, is it's a fixed belief. Idea of reference is a belief which is not fixed like a delusion. So here the right answer is, beta, what we know patient can have some of those somatic symptoms like tingling of extremities. Very good. So also, if you know that classification of neurosis of psychosis, now that also will help us solve many questions. But first of all, now you have to make the diagnosis. So यहाँ पे जो diagnosis है बेटा वो है, they're trying to tell you that there is some neurotic illness like GAD is there, and the right answer is option number B. See, sometimes such direct questions are also asked. Morbid fear of darkness. So can I say that person is having a fear to a particular situation or object? उसको क्या कहते हैं बेटा? Specific phobia. This is what? Can anybody tell me this is what? This is nyctophobia. Very good. Claustrophobia is closed spaces. Xenophobia is what? Xenophobia. In pathology we read na xenograft when it is taken from a different species. Xenophobia is fear of strangers. Fear of strangers. And mysophobia is fear of dirt or germs. So here the answer is, it is nyctophobia. Very good. What is acrophobia beta? Acrobats, they do stunts on height na. Acrophobia is fear of heights. So you may be asked such clinical question. Now they may frame such clinical questions also. So please be very careful. See the options and then mark the answer. Let's now come to this question. Again, recent question 2024 का question है. A 25-year-old female has visited multiple plastic surgeons requesting correction of face deformity and was referred to the psychiatrist. So maybe there is no face deformity, but person is having some of these thoughts. She repeatedly checks her face in the mirror, insists that her face is deformed and needs surgery despite no such evidence on examination, constantly examine herself on utensils, spoons, complaining about spots and blemishes that are not present. The patient persists her demand despite reassurance from doctors, from family members. So can you tell me what is the right diagnosis here? Very good. It is body dysmorphic disorder. Very good. So patient is preoccupied of defects in the physical appearance. So they have not told you in the question that the diagnosis is this, and now in fact they have asked you the management. So can anybody tell me beta what is the management here? Very good. See, in the management beta, drugs like SSRIs have shown very good results. Now also when we are managing this patient, we are not just using beta behavior therapy, we are also using cognitive part also. So CBT is the treatment which therapy mein that can be used. So from the options, can you appreciate? The answer is SSRI. Okay, so the answer is SSRI. Also, in fact, this topic is very important. The topic is beta, this is now included under obsessive compulsive and related disorder. So OCD is a very important topic. Patient is having repeated obsessions and there is a repetitive behavior also, or some acts patient is repeating. BDD we have discussed. Hoarding disorder, patient is hoarding, collecting things which are of little or no value. Trichotillomania mein patient is pulling the hair, with a patch of alopecia. Beta, you may be given this image of a patch of alopecia and you have to see whether it is because of some dermatological condition. Yeah, it is because of trichotillomania. So when you see the margins are irregular, the hair length is unequal. So this is telling us, very good. This is telling us, beta see, I told you na, because we are using both. देखो, सिर्फ behavior therapy use नहीं कर रहे बेटा यहाँ पे हम, we are using both. CBT is cognitive behavior therapy. So cognitive therapy is when we are trying to change the thinking, and behavior therapy mein we are trying to change the behavior. So here we are also targeting the cognitive, the thinking of the patient. So not just behavior therapy, but we are using cognitive behavior therapy. So out of the options beta, SSRI have shown good results. Also, what is excoriation disorder? Here now the person is picking the skin. Again, patient may present to us with some skin lesion, but it is not because of dermatological condition, it is because of psychiatric condition. I hope this is clear. वो trichobezoar वाला बेटा point भी also remember ना, वो image we have discussed ना, कि patient comes to us, there is a mass of hair in the stomach, it has taken the shape of the stomach, trichobezoar, and now the patient should be referred to after surgery to the psychiatrist because it is because of trichotillomania. Very good. Let's see another question. Now see this question. In fact, this is a question of 2018. Now you'd see such a nice clinical history has been given, so I am discussing this also. Let's try to answer this question. A 35-year-old man presents to the psychiatry OPD with a history of road traffic accident 2 months back with multiple fractures. So in the question, they're giving you some, trauma, some serious stressor is given. He recovered physically, but for the last 1.5 months, he has been having sleep disturbances with dreams in which the incident of accident was getting repeated, and wakes up often feeling anxious. Also, he used to get startled while walking on road, hearing vehicles. Which of the following is the diagnosis? Can you tell me better what is the likely diagnosis here? Very good. So all of you have also identified the key points. Very good better. Duration is very, very important. After a stressor, can you appreciate better? We've discussed after a major stressor, mahi wale symptoms, mood and cognitive symptoms, very important. A for A for beta avoidance symptoms, and I for intrusion symptom. Like here he's getting dreams, distressing dreams are there, sleep problems, hyperarousal symptoms startling are there, and the duration is 1 month or more. Diagnosis is PTSD. If the symptoms are similar but the duration is less, the diagnosis would change to beta acute stress disorder. So please be very careful. So sometimes they will give you both the options, see the duration and then try to get to the right answer. Great. So this is again an important, small but important topic. Now see this question. A 21-year-old female presents in the emergency with complaints of amnesia of events for the past 2 weeks since she lost her father in a road traffic accident, and she gets flashbacks of the event. Again, can you appreciate here beta ab kya answer hoga? And now in the question they are giving you a stressor, okay, and the duration they are giving you, and they are giving you symptoms like flashback is there. She's not able to remember also. So answer yahan pe kya hai beta? Now it will be, see the symptom, the adjustment disorder we have discussed. It's a diagnosis of exclusion. It's a diagnosis of exclusion when the symptoms you are not able to make any other diagnosis. Symptoms are emotional behavioral symptoms after a stressor, and usually a mild to moderate to teen stressor, and you are not able to make any other diagnosis. But here, can you appreciate the symptoms are suggesting more towards acute stress disorder? So the answer is option D. Very good. You should also know beta how to differentiate other conditions. Okay, PTSD of course we have ruled out now. We have ruled out because the duration is less. Okay, so please remember the answer is option D. Let's now see this question. Which of the following types of OCD has poor response to the exposure and response prevention? So we have talked about this when we discussed that now we have OCD and related disorders, and we've discussed in hoarding disorder, but we say hoarding disorder is difficult to treat. Hoarding disorder is difficult to treat. So we are using therapy like CBT, but it is difficult to treat because patient may have poor insight to the condition. Patient may also have low, patient has low motivation, or there is resistance to treatment. So hoarding disorder, remember, it is difficult to treat. So out of these options, the right answer is option C. So somewhere in the previous year questions ki trend mein, we are able to see that somewhere they are asking some questions with OC and related disorders. Okay, so please be very careful with these important diagnoses. Let's now discuss this topic which now you will see have been asked in exams: dissociative disorders and somatoform and related disorders. So let's try to answer this question. A very interesting question came last year. A patient is brought to the hospital found wandering in another city by a social worker. The social worker is reporting that he has been living in his town and he belongs to a nearby town. Just after a recent earthquake hit, he was brought here. He doesn't remember his identity and how he reached 110 kilometers far from his home. There is no history of any substance abuse. Medical evaluation is normal. Family members are concerned about his condition. But can you appreciate here they are mentioning you there is a history of travel beyond the normal range travel, and there is amnesia of the past, and person may assume a new identity. So beta, what is the right answer? The right answer is it is dissociative fugue. And so remember we talked about dissociative amnesia, dissociative fugue, dissociative identity disorder, or multiple personality disorder. One person has 2 or more personalities. So question on multiple personality disorder may be asked like this, that a person comes home and see himself in the pictures on social media account with strangers, and in those pictures the person is smiling and seems to be having a good time. Also the family members report that there are some times, some days in which the person may behave in a very different person, as a different person. Diagnosis. Then you are thinking of dissociative identity disorder. Very good. Yes. So yes, we've also discussed that movie also. No? Very good. So yahan pe answer is dissociative fugue. Let's see this question again, beta. These are very important topics. So let's talk about this. A young girl presented with a history of multiple episodes of loss of consciousness lasting for 20 minutes. These episodes occur only in front of family members and only in the daytime. They're not occurring in night. There is no history of tongue bite, incontinence, e.g. MRI studies are normal. So it is, it may appear like a seizure, but they're trying to say that it is not a true seizure. It is pseudo seizure. Very good. It is pseudo seizure. So what is the diagnosis? First, you can tell me the diagnosis. We have talked about this now, conversion disorder. Now in DSM-5 known as functional neurological symptom disorder. Patient has motor or sensory symptoms. It could be motor symptom like hemianesthesia, blindness may be there, or motor features like hair pseudo seizure are there. And also patient may have la bella indifference. This again is a very important term, na? Careless attitude towards serious symptom. And in the management, beta, we have talked about these conditions. Management is therapy such as CBT, but here in the option, see, one of the therapies, again not commonly used, but yes, from the options beta we can choose insight oriented psychotherapy. So therapy is used. See, aversive therapy is, we are giving any noxious stimulus, and we don't use it very commonly, noxious stimulus. For example, let us say a person who is smoking, every time he smokes, a mild shock is given. So this is like aversive therapy, usually not very commonly used. So out of the options, but it is not a true seizure, so we're not giving valproate. So answer is option B. Very good. Also, see, we have talked about this now. Also remember, in somatoform disorder, this again is very important. Let me see if you can identify, can differentiate, beta, what is the difference? How will differentiate somatic symptom disorder or somatization from hypochondriasis or illness anxiety disorder? This again is very, very important. If, see, in these conditions, you will see patient is having some symptoms, but investigations, examination, everything is coming out to be normal. So somatic symptom disorder, as the name suggests, patient is worried about the symptoms. So I'm having pain, or there is breathlessness, so some symptom patient is having, and investigations, examination is coming out to be normal. While in hypochondriasis or illness anxiety disorder, beta, what is happening? Can you tell me what is happening? Here the person is worried of having a serious illness. So if somewhere in the question patient is worried to have a serious illness now, then I'm thinking of illness anxiety disorder. Very good beta, you are getting it correctly. Yes, aversive treatment में एक drug हमने discuss किया in alcohol ना, कौन सा, which is an aversive agent, disulfiram, क्योंकि वहाँ पे भी unpleasant symptoms आते हैं ना, so then we are using that disulfiram in alcohol, which we'll discuss. Yes, so right answer बेटा यहाँ पे क्या है? Option B. यहाँ पे diagnosis क्या है बेटा? What is the diagnosis here? Can you appreciate pseudo seizure? ना, it is conversion disorder. Diagnosis is conversion disorder, and conversion disorder is more common in females than males, especially in younger age. Okay. Now let's see this question. Now we are entering this very important topic of substance. है ना? Substance में nearly in every exam now you are seeing questions on substance use disorder. So please be very careful. A male patient stopped taking alcohol for 3 days, 72 hours, and presented with symptoms of irritability, disorientation, paranoid delusions, visual hallucinations, altered sensorium. You have to tell me the diagnosis. So all of us will say, sir, it is alcohol withdrawal na. So I can easily rule out C and D. We'll discuss Wernicke's and Korsakoff syndrome. तो alcohol induced neurocognitive disorder है. यहाँ पे clearly they are telling you कि patient ने stop किया alcohol, develop these withdrawal symptoms. It is A or B. Very good. Why this is better? Why you are saying it is delirium? Can you justify your answer? Why it is delirium tremens better? Why delirium tremens? So we have discussed about these withdrawal symptoms now. That usually in 6 to 8 hours, tremors, most common withdrawal symptom, then alcoholic hallucinosis, seizure, and delirium tremens can occur. But we have discussed now, remember that mnemonic ACDC. Here in the question, they're telling you patient has disorientation, there is altered sensorium. So consciousness now is impaired. So now I'm thinking of delirium tremens. It's an emergency. Okay. So please remember this. So I hope you can differentiate between alcoholic hallucinosis and delirium tremens na. In alcoholic hallucinosis, देखो hallucination दोनों में हो सकती हैं. And the difference is not the duration, not the hallucination, but remember कि alcoholic hallucinosis में the consciousness is intact. Delirium tremens में the consciousness is impaired. Let's see the next question. Again, you will see, such question being asked. A 50-year-old male patient is a chronic alcoholic, presents to the emergency with irrelevant talks, disorientation, tremor, and sweating. And they're telling you his last alcohol drink was 3 days ago. So he's again in withdrawal symptoms. Again, the answer is, can you appreciate? Very good. It is delirium tremens. So again, somewhere they are trying to tell you that there is impairment of consciousness. So it is now delirium tremens. Very good. Let's see this question now. So management pe bhi you will see, in fact, in 2024 only the question was asked. A patient brought to the hospital after a road traffic accident with symptoms of confusion, irritability, tremors. He has history of consuming alcohol daily. So can I say because of the accident he is admitted in the hospital and suddenly the alcohol is withdrawn, is stopped? Which of the following drug will you use in the management? So we have identified this is alcohol withdrawal na, delirium tremens hai, and we know in the management of withdrawal symptoms, beta, if they are asking you, lorazepam is the answer, benzodiazepine. if option would have been benzodiazepine plus thiamine, then that could have been a better answer. But out of lorazepam and thiamine, if you have to choose one in the management of alcohol withdrawal, it would be benzodiazepine. So we have talked about this. Withdrawal mein, detoxification phase mein beta we can use these benzodiazepine. Also, if there is a liver disease, you can remember which benzodiazepine you can prefer: liver okay benzodiazepine, lorazepam, oxazepam, and we can also add thiamine. In the maintenance phase beta, one drug we have is disulfiram. And what is the mechanism of disulfiram? It is aldehyde dehydrogenase inhibitor. It's an aversive agent, as most of you are saying it correctly. And also we have some anti-craving agents. Remember naltrexone, which is opioid mu antagonist, and a camproside, which is an NMDA antagonist. These are FDA approved anti-craving agents for alcohol. So this again is a very important point, beta. Please remember. Acha, a patient who is taking disulfiram tablet and over that he consumes alcohol. Now he goes to a party, he consumes alcohol. Beta, what reaction would occur now? He would develop unpleasant symptoms like nausea, vomiting, flushing, and what is that known as? Disulfiram ethanol reaction. Please remember this. Okay. So I hope you know where to use benzodiazepine, where to use these drugs, and where to use thiamine only. We'll discuss that also. Okay, so the answer here is option C. Let's now see this question. Again, important topic in alcohol. A chronic alcoholic patient presents with symptoms of acute onset of confusion, sixth nerve palsy, nystagmus, ataxia. Beta, alcohol ki history, Goa wale symptoms hain. What diagnosis? So see, sometimes if you see any video based question also can be asked, that patient comes to the emergency, there may be nystagmus in the eyes, or the eyes are deviated to one side, or they may give you a video of a person who is having ataxia, he's falling, not able to walk steadily. So all these symptoms person is having. So this is suggesting of Wernicke's encephalopathy. So again, very important, remember Wernicke's encephalopathy and Korsakoff syndrome. Remember the mnemonic Goa wale symptoms, and in Korsakoff patient is having amnesia and even confabulation can be seen. The cause is vitamin B1 deficiency and treatment may we give thiamine. I hope this is clear. And always when we're talking about this chart, now we discuss two extra points, and you would appreciate beta one of those points was asked finally in the exam. So let us see if we can answer this question. So that is why I'm saying nowadays now they're asking a lot of questions which is checking your clinical judgment. What to do next? A person chronically consumes alcohol. He indulged in binge drinking 10 days back and was brought to the emergency in an unconscious state. So he's unconscious, but normal findings on non-contrast CT. So they're trying to rule out that there is no brain pathology, there is no any cause like a stroke or a injury, and his blood glucose they're mentioning is 45. So they're trying to tell you it is maybe because of hypoglycemia. So we are now going to give him glucose. So what is the right answer? But in such a scenario, alcohol ki history, we're always giving thiamine followed by dextrose. So please remember this, that is the answer. Let me ask you another situation beta. Let me see if you can answer this question. History of alcohol hai, Goa wale symptoms hai, you're suspecting Wernicke's. So another FQ beta I am discussing, this can come as a new question. So alcohol ki history, Goa wale symptom, Wernicke's, you're suspecting but no response to thiamine. What will be your next step? Now what you're going to do, can anybody tell me beta? Symptoms to Wernicke's hai, but it is not reversed by thiamine, so it is not Wernicke's. It could be because of very good pelagic encephalopathy. So now we are going to give niacin. Very good. I hope this is clear now. So such scenarios may also be asked. Okay. Now let's see the next question. So in substance, alcohol becomes a very important topic, and also you will see a lot of questions being asked even on opioids. So let's discuss better some important questions which have been asked on opioids. Let me see if we can answer this. A patient with suspected opioid overdose, they are giving you this, comes to the emergency with respiratory distress, bradycardia, hypotension. Tell me what is the drug of choice. What is the drug of choice? So this is opioid overdose. So one more clinical finding, can anybody tell me? They're telling you that there is respiratory depression. Okay, there can be coma. One more important clinical finding, can anybody tell me? In the eyes, very, very important is, yes, all of you are correct, but it is IV naloxone, which is a opioid mu antagonist short acting drug. Very good, beta. Please remember also pinpoint pupil or meiosis. Okay, and the treatment is IV naloxone. So you'll see this question being asked. In fact, in many exams, you will see question on opioid overdose or intoxication has been asked. So very good. Let's see another question. So even recently they've asked question also in the management of opioid maintenance. So let us see if we know the concept we have discussed na, opioid के management में बेटा withdrawal phase we manage, withdrawal phase, and then we have maintenance wala phase. Let me see if you can answer this question. Withdrawal phase में if you remember we use opioid drugs like methadone, like buprenorphine, or we can do symptomatic management beta, symptomatic treatment. जो symptoms हैं like clonidine we give to decrease the sympathetic symptoms. Maintenance में one of the strategies if you remember is opioid substitution therapy. We substitute impure opioids with the pure opioids. So यहाँ पे भी we are using drugs like methadone and buprenorphine, and one more drug we can use is naltrexone. You know, we are using the antagonist property of naltrexone. So just like we discussed the management of alcohol in 2 phases, na, so we discussed the management of opioid also. So now tell me, very simple, na? The answer is what? Bupropion, it is not. And a clonidine we can use in the withdrawal phase. And a disulfiram so we are using in alcohol maintenance. The answer is buprenorphine. I hope this is clear. What is buprenorphine? It is a very good. It's a partial mu agonist. It is a partial mu agonist. But how to remember? Remember na, buprenorphine, morphine, and it is rhyming also. Remember it like this. Okay? So answer is, it is option C. Let's see one more question. So sometime you'll see questions on tobacco also. Which of the following drug is used for smoking cessation? Let us see if we can answer this. So again in smoking cessation beta we have 2 strategies. One is NRTs we have, and then we have some anti-craving agents. We have some anti-craving agents. So NRTs, we have an anti-craving agent. Very good. What is the drug we can use here? Out of the option beta, it is varenicline. What is varenicline? It's a partial agonist of alpha 4 beta 2 N-acetylcholine receptor. See, in the name only na, you can remember Nic is coming na. So it is partial agonist of alpha 4 beta 2 subunit of nicotinic acetylcholine receptor. Okay, one more drug beta we have. So one is varenicline, and one more we have is bupropion. What is bupropion? It is a NDRI. So antidepressant used for beta smoking cessation would be, it would be bupropion. Also remember few points beta about the nicotine replacement therapy. Can you tell me some ways in which NRTs are given? Like gums are given, nicotine gums are there beta. And can you tell me beta what is the method? So these nicotine gums, they are not chewed like normal chewing gums. What is the method? Do you remember what is the method? There are lozenges also. Very good beta. Lozenges hain, patches are there, then inhalators, so many other forms are there. Can anybody tell me what is the method of using? Very good. It is chew and pack. So person chews it for few minutes, then there is a tingling sensation, peppery sensation, parks between the gums and the teeth, again chew, then again park. So this is done multiple times. Also when person is using nicotine gums, the person should avoid acidic drinks like cola, like coffee 15 minutes before and after using these gums. So remember some of these points as well. So यहाँ पे answer is beta, it is varenicline. Very good. Let's see the next question. Most widely abused substance causing dependence. Beta see यहाँ पे alcohol नहीं है, tobacco नहीं है. So in India, beta in India if I ask you most common substance, you will say sir tobacco followed by alcohol. That is not given. Now so these are licit substances. So then you can say sir most common illicit substance कौन सा है? Tell me. Then you can answer it is. So these options are not given. Then you can go with cannabis. But also remember, if along with tobacco, alcohol, this substance is given, then that becomes the most common. कौन सा substance we are talking beta? That is caffeine. Caffeine now is also considered as a substance use disorder. So so many people consume caffeine in the form of tea, coffee, even cola drinks. Caffeine also now is considered as a substance use disorder. So if that is asked, given in the option and asked most common, then you can go with caffeine. Also remember, yes, amotivational syndrome beta is used for, है ना? Tell me, amotivational syndrome is again associated with amotivational syndrome. Remember, again is associated with cannabis. Okay, associated with cannabis. Cannabis beta intake में, cannabis intake, person is taking cannabis, he has recently taken intoxication है. Person का mood कैसा होता है? Person may be very happy. Person may report sir slowness of time, ऐसा लग रहा है वक्त थम गया है. Also you will see in the eyes there is redness of the eyes because of conjunctival congestion. Also parents or family members may report that he is eating a lot, increase in appetite. So these points again are favor of cannabis intake. So remember some of these important points. Very good. Let's see the next question. Again this is a topic I've been always discussing cocaine. It's a stimulant, but it's a small topic, but you'll see many times question being asked. Which of the following is not seen in patient who use heavy dose of IV cocaine or cocaine intoxication? But very simple to remember now. I've discussed cocaine a stimulant, it increases the sympathetic activity. Just from that logic only tell me what is the right answer. The right answer is beta here option number B, that is bradycardia. So we talked about cocaine, it's a stimulant. Also remember, if you see in the eyes, what will happen? What you will see, the finding in the eyes, it will be mydriasis. Please remember, we have talked about this point, TCA toxicity beta, cocaine and amphetamine. Amphetamine is also a stimulant. There you are seeing mydriasis. Cocaine is associated with which hallucination? Remember, we've talked about this now, that it is associated with cocaine bugs or magnum bugs. So patient with tachycardia, tachypnea, scratch marks comes to us. Which substance he is consuming? He is consuming cocaine. Okay. Speedball is a combination of cocaine with opioids like heroin, and sometimes they may give you beta images also, like a person, people consume cocaine through snorting, it causes vasoconstriction. In the long run, beta, can anybody tell me what is the finding in the nose? One may get sometimes nasal septal perforation, so they may give you such images, or in the tongue you will see jet black pigmentation. Such images may be given. So again here integration with ENT and psychiatry may be done. Sometimes integration with psychiatry and opthal may be done beta. Eye में important findings remember ना, we have discussed कि cornea पे और lens पे there is deposits. Tell me cornea और lens पे deposits हैं, तो what you are thinking? कौन सा important antipsychotic beta you are thinking? C for cornea, C for chlorpromazine. Okay, please remember this. So sometimes they may give you images beta, split lamp image दे देंगे, there is deposits. Also tell me अगर retina पे pigmentation है बेटा, retinal pigmentation है, then which drug you are thinking of? Remember, then we are thinking of thioridazine, है ना, thioridazine. So sometimes such integration may be asked, so please be very careful. Okay, now let's go to the next question. Answer this question now. I'm sure all of us can answer. देखो अभी recently asked question 2024 का, a mother reported that her daughter ingested a substance in an unknown dose. The girl presents with hypertension, tachycardia, mydriasis, hyperthermia. So again they're telling you there is increase in the sympathetic activity, mydriasis is given. Heroin, morphine, beta, these are opioids. Usually they will be associated with meiosis, isn't it? So यहाँ पे answer क्या है बेटा? Again the answer is cocaine. So try to see the question and then answer. Let's see the next question now. And let's now discuss few questions on child psychiatry, and I'll give you one update beta. Remember that new drug ka naam we'll discuss. And also in fact beta यहाँ पे ना also remember nowadays when we're talking about substance use ना, when you're talking about substance use we also talk about certain addictive disorders, and nowadays certain behaviors are also becoming similar to having a potential of addiction. So just like substance use disorder, that may also lead to disruption in functioning. And two important disorders, but now newer classifications, they are including two disorders. Remember, one is gaming disorder. So ICD-11 also considers now gaming disorder as a substance use and addictive disorder. So they may give you in the history a 16-year-old boy spending 10 hours, 15 hours every day, playing games. He's not able to control his behavior despite there are negative consequences. His academics are declining, functioning is getting impaired, not able to stop this behavior. So then you're thinking of gaming disorder. And one more, remember beta, that is gambling disorder. Even gambling disorder now is considered as a substance use and addictive disorder. Let's now discuss questions on child psychiatry. Very good. Yes, है ना? As per the American Psychiatric Association, the new term in DSM-5 for mental retardation, yes, all of us know it is intellectual disability. Okay, so please be careful. Such questions, if asked, some of these newer terms also, like conversion disorder, we know, functional neurological symptom disorder. Okay, hypochondriasis in DSM-5 is illness anxiety disorder. Sometimes they may not ask question directly like this, but option mein they will give you those new names. Okay, so please remember those new names. Let's discuss this question. Again, a very interesting question, beta, which was asked in your 2024 ka exam from child psychiatry. Let me see if we can answer this. Which of the following is a selective NRI drug? Selective NRI drug, norepinephrine reuptake inhibitor drug. So let us see beta if we can answer this question. Selective NRI drug kaun sa hai? We know methylphenidate, see methylphenidate, it increases both norepinephrine and dopamine. It affects both. Modafinil, it's a alpha 1 agonist. Guanfacine, beta, it is a alpha 2 agonist. We know that there are CNS stimulants like methylphenidate. Amphetamine again is also affecting both norepinephrine and dopamine. They are asking कि selective norepinephrine reuptake inhibitor beta कौन सा है? And non-stimulants, we know there is atomoxetine, which is a SNRI beta, that is selective norepinephrine reuptake inhibitor, but which is approved by the FDA. Okay, but देखो option में ना they have given reboxetine. See, it is one of the drugs which is used in some European countries to treat ADHD. It is a similar category to beta. देखो नाम भी same है ना, atomoxetine, reboxetine. So sometimes you have to see all the options, rule out the options, then you're only left with reboxetine. So please remember यहाँ पे बेटा answer is it is rebox. Also remember बेटा CNS stimulants, they are contraindicated in cardiac illness. So if somewhere in the question they are telling you कि patient has a family history of sudden death or there is some cardiac disease in the child, then we are thinking of non-stimulants. Also remember clonidine, guanfacine, they are also used as the first line treatment for tics. So a child with ADHD and tics, so then we are thinking of non-stimulants and we may prefer drugs like clonidine, guanfacine. But now there is one very important new update which I want all of you to write down in your notes. Very recently, just a few days ago, this new drug has been now approved for the management of ADHD, and it's a very unique drug in the form of its mechanism of action. So this is one drug update beta. Please highlight this in your notes. Please write this down when you're revising. The name is so the name is centanafadine. So I'll tell you how to remember this. Centanafadine, this is a triple reuptake inhibitor. In fact, it is NDSRI. So it is affecting all the three: norepinephrine, dopamine and serotonin. It is affecting both, all the three. In fact, it's a triple reuptake inhibitor. So please remember this name, centanafadine. And how to remember, you can just remember it like this. But see, from the name now, F say you will remember 5-HT, serotonin pit is acting, remember it like this. A say remember adrenergic, so norepinephrine pit is acting, and remember D say it is dopamine. So all the three it is acting. So please remember this. They may just ask you a new drug which has been approved for management of ADHD, which is acting on all the three neurotransmitters. So remember this name. ठीक है ना? Please remember this update. Let's now discuss the next question. Untreated ADHD child persisting in childhood increases the risk of development of which of the following in adolescence? Tell me, a child having ADHD and the symptoms persist in adolescence. Better tell me what is the right answer. Conduct disorder. Very good. Also, in fact, there is an increased risk of mood disorders, even substance use disorder. Achha, can anybody tell me if these symptoms persist, if they persist in adulthood? If they persist beta in adulthood, then what chances are there? Very good. Which personality disorder? Antisocial personality disorder. Along with, yes, mood disorder, substance use disorder also may be a higher risk. Very good. So we have covered the child psychiatric topics, but now we are going to discuss some miscellaneous topics, and these miscellaneous topics, you will see some of the topics are being asked again and again. So let's discuss better one of the topics, that is sexual disorders and some related disorders. So let's see this question. So earlier they were asking very simple direct questions. Squeeze technique is used for which of the following beta? And now we have talked about this now. So we know that erectile dysfunction is there is premature ejaculation. Also remember, there are disorders of which phase of sexual response cycle. So we have remembered the stages of sexual response cycle with the mnemonic DEOR. There is desire phase, excitement phase, orgasm and resolution. We know that excitement phase mein erection occurs, so erectile disorder is a disorder of excitement. And we know orgasm phase mein ejaculation occurs, so premature ejaculation is a disorder of orgasm phase. Erectile dysfunction mein beta, please remember the name of these therapies which are used: sensate focus technique, and also we can use drugs which are PDE5 inhibitors. While when we are managing premature ejaculation, two important techniques which you will remember is squeeze technique and stop start technique. And in the drugs, we are using side effect of SSRI. They cause delayed ejaculation as a side effect. We are using that side effect in the management. So all of you are right, but yes, it is used for premature ejaculation. Let us see this question. Now you'll see, they are also framing some clinical questions. Question is very simple, very similar, but they have made it in a clinical way. A male patient comes with a history of marital conflicts and complaining of early ejaculation. So diagnosis you are making is PME and DSM-5, but a DSM-5 also uses the duration if it is less than 1 minute. So what is a non-pharmacological method you are going to use? So in a way, they are again asking you which therapy we can use. The answer would be what? But see the answer PME, we have just discussed, the answer would again be squeeze technique. I hope this is clear. So earlier it was a direct question which was asked, and now they are giving you a clinical question. So identify the condition, you can identify, and then you can answer the question. I hope this is clear now. Very good. Now let's answer this question. So now if you know the basics well, now you can answer such question. Tell me, premature ejaculation is a disorder of which phase of sexual response cycle? We know that ejaculation is occurring in the orgasm phase. So any problem in ejaculation would be a disorder of what phase, beta? It's a disorder of orgasm phase. So that is why I'm saying focus on the concepts. We can then understand and we can remember these points. See, also you'll see many questions from paraphilias. And paraphilias would be a topic you would also read in forensic, also in psychiatry also. So please remember paraphilias also, because paraphilia makes sometimes you're getting questions. An elderly male was sitting in the balcony naked, showing his body parts. The neighbors complained to the police and said that he does this particularly in the evening in front of people when they're walking in public park. What's the likely diagnosis? Beta, there is, he's exposing his genitals. So paraphilias, may we know, the person is getting sexual gratification by ways, by methods which are deviated from the normal behavior. So paraphilias. Okay, what is masochism? M for masochism, myself. Person gets sexual gratification by getting hurt himself. So there is injury, trauma to self, myself. Voyeurism, beta, there is O coming now, we have remembered. So person is getting sexual gratification by observing people engaging in sexual activity or some intimate behaviors. Fetishism is when the person is getting sexual gratification by non-living objects or non-genital body parts. For example, the person is getting sexual gratification by shoes, by gloves, or by legs, by fingers. So then that is fetishism. But also remember, there is something known as frotteurism. Frotteurism kya hai beta? Frotteurism is double T is coming, the person is rubbing or touching people in public, strangers, and getting sexual gratification. So please remember some of these important, very good, some of these important paraphilias. Let's try to answer this question. Now question I'm sure is simple, but I want you to remember some important difference between two options. A 30-year-old male needs to be dressed in female innerwear and high heels to feel aroused and have intercourse with a female. He denies any attraction towards male. What is the likely diagnosis here? Again, this is a paraphilia. Again, this is a paraphilia. And what is the paraphilia? This is transvestism or transvestic fetishism. Earlier it was known. So this is transvestism. Okay. Now also remember, gender dysphoria mein there is a disorder that is transsexualism. Now in transsexualism also person may wear clothes of opposite gender. Now can you tell me how will you differentiate? So answer is option B only. It's a paraphilia. Very good. Okay, tell me what would be the differentiating factor? दोनों में ही देखो, just see the name. Transvestism is, trans means opposite, vestism means clothes, transsexualism opposite gender. Tell me in both situations you will see that person may be wearing clothes of opposite gender. Beta, how will you differentiate? How will you differentiate? Transsexualism may be a person, let us say a male is wearing clothes of opposite gender or female. But here the person wants to live like opposite gender, wants to live like a female. यहाँ पे the reason of wearing clothes of opposite gender is to get sexual gratification, right? So that is why you should also know the difference. Next time if they use these terms in the question, it may confuse us. But now I'm sure now we have understood it, so we'll not be confused. So answer is option B. Let's now see this question. So in sleep disorder, you'll see sometimes questions are asked, and if you see this question, I'm sure you can answer. Is false about somnambulism. See, somna means sleep, ambulism means walking. So sleepwalking. And when we talked about the sleep physiology, but we understood now some basic concept. We know that generally in REM, the muscle tone is in a state of paralysis. So movement usually occur in NREM. So can I say sleepwalking is a NREM ka disorder? It's a NREM ka disorder. You have to tell me the false statement, beta. Yes, consciousness is not preserved. The person is unconscious. So this is the incorrect statement. It is a disorder of sleep arousal, partial arousal, sleepwalking, and low level of motor skill is present. Person may engage in some motor activities like even complex activities, but throughout that the person is unconscious. Person is in a sleeping state. So answer is option D. Let's see this now. This image, if you can appreciate, let us see. The EEG is shown below. You have to tell me what is the stage. Okay. हाँ बेटा देखो, I'll explain you again. देखो, don't get confused. Gender dysphoria क्या होता है? Gender dysphoria में ना person wants to live like a opposite gender. So a female or let us say a male says, sir, I want to live like a female. I want to live like a female. Person को कोई sexual gratification नहीं है. Person says, I want to live like a female. Okay, so there is a desire to live like a opposite gender. So person may wear clothes of opposite gender. जबकि transvestism में person is wearing clothes of opposite gender कि उसको सेक्सुअल ग्रेटिफिकेशन मिल रहा है, लाइक इन दिस सिनारियो. ठीक है, लाइक इन दैट सिनारियो. नाउ कैन यू अप्रिशिएट बेटा सच वेव्स इन द इमेज. नाउ व्हाट इज दिस? दिस इज सॉ टूथ अपीयरेंस. दिस इज सॉ टूथ अपीयरेंस. एंड वी नो, देखो REM में वी नो दैट वी आर स्लीपिंग बट EEG shows बीटा एंड अल्फा वेव्स. Those waves which are present when we are awake. That is why हम REM sleep को क्या कहते हैं बेटा? We call it as paradoxical sleep. Usually these beta waves and alpha waves, these are fast activity wala wave and they are present when we are awake. Right now we are awake, eyes are open, beta waves. We close our eyes, we are awake, alpha waves. है ना? This question is also asked sometimes कि when is alpha wave seen? That we are awake and the eyes are open, eyes are closed. But also remember, these are also seen in REM. And this appearance, classical appearance is sawtooth appearance. Also tell me beta, N2 में क्या मिलता है? N2 में what we find? Very good. Remember N2 when are two findings. One is sleep spindles. One is sleep spindles. They are sudden burst of electrical activity like this. And then we also have K complexes. K complexes, sharp positive, negative waves. Okay. So answer here is REM sleep. I hope this is clear now. So please remember this. Let's go to the next question. So it's a very interesting question which was asked. Let us see if we can answer this question. A 16-year-old female patient was referred to psychiatrist by the physician for having irresistible urge to eat. So there is craving for food and it is, excessive eating followed by there is episode of self-induced vomiting. And patient is also on appetite suppressant. Tell me the diagnosis, A or B? A or B? Why not A? Patient is also on appetite suppressant. Why not A? All of you are correct, beta. This is bulimia nervosa. Very good. Why not A? Because we know in anorexia nervosa patient is eating less. In that also there can be binge eating, purging, but very important we know that the weight or the BMI, it should be given that it is reduced. This is very important point for making a diagnosis of anorexia nervosa. Very good. But देखो Russell sign वो सब can also be seen in anorexia nervosa because anorexia nervosa में भी there is one subtype ना, anorexia nervosa का binge eating, purging type. But remember, in anorexia nervosa, the weight BMI is reduced. That should be given in the question. Nowhere it is mentioned. So please remember, then we are making this diagnosis of bulimia nervosa. Now tell me, a patient with bulimia nervosa also has depression. We are planning to start an antidepressant. Which antidepressant should you avoid in this patient, beta? So such clinical scenario may be given. A patient with bulimia nervosa also has depression and we are planning to start an antidepressant, but which important antidepressant you will avoid? Very good. Remember bupropion. Bupropion has a side effect of seizure. In fact, both in even anorexia nervosa and bulimia nervosa, patient may have electrolyte imbalance. Like in bulimia nervosa, patient has self-induced vomiting. So patient may have electrolyte imbalance, risk of seizure is increased. So bupropion देने से the seizure may actually occur. So it is avoided. Please remember. Also remember the complications, beta. Nowadays questions on complications are also asked, like complications of purging. Okay, HCl is going out now. It would lead to metabolic alkalosis or acidosis. Metabolic alkalosis. Okay, so please remember this. Let's see the next question. In fact, the last two exams of NEET PG, you would see questions on personality disorder. So please revise personality disorders also. You will see questions on personality disorders. A 24-year-old male presents with evaluation, appearing very calm and charming, behaves well in front of the psychiatrist, however, gets into fights with friends, bunk classes, break traffic rules, involved in multiple police cases. So they are characteristically giving you this history of what beta? Antisocial personality disorder. Remember, cluster B mein there is antisocial, where violating rights of other person is doing. Borderline personality disorder, very important, unstable relationship, recurrent suicidal behavior. Therapy for borderline personality disorder, remember DBT, dialectical behavior therapy. Histrionic personality disorder mein beta key feature is person wants to be the center of attention. And narcissistic personality mein there is a heightened sense of self-importance, that I am more important. Person may exploit others. So I'm trying to tell you beta some unique key points which will help you reach to these diagnoses. Let's see one more question from personality disorder. This was last year ka question. Again, if you see the question, I'm sure you can answer this now. Right, very good. So now you can able to identify such conditions. Very happy to know. A friend of patient Mr. K reports Mr. K is very obsessed with his schedule and overly focused on rules and details, very rigid and about perfection, wants to manage everything systematically, and he's been doing since adolescence. See, they're telling you it is the onset is in the adolescence. The characteristic onset we would see in personality disorder. He does not agree with his friend, is not ready to seek any treatment because patient is egosyntonic. Patient does not think that he is having any problem. Okay, and this in fact helps us differentiate from OCD. OCD means the patient knows that these are unacceptable thoughts. He is trying to resist them. So here this is a classical case of obsessive compulsive personality disorder, where the person is preoccupied with rules, details, perfectionism, with very rigid, very stubborn. Dependent means the person is dependent on small decisions, everyday life decision. Anxious avoidant means person is extremely sensitive to rejection. What if somebody rejects my opinion? So person may not give their opinion in public. So this is anxious avoidant personality disorder. Very good. Let's see the next question now. So lithium again is a very important topic in pharma also. When you're revising, lithium is very important. A male patient was on lithium for bipolar disorder. He did fasting for religious reasons for 2 days beta. Fasting, like we have discussed, dehydration, diarrhea, vomiting, that can increase the lithium levels. Lithium toxicity ho sakta hai na. And actually the patient is presenting with vomiting, coarse tremors, nystagmus. So what you're suspecting? We are suspecting lithium toxicity. So we have discussed these important signs and symptoms, beta lithium toxicity, mild, moderate and severe. Okay, so what you are going to do first is, out of the option beta, we are suspecting lithium toxicity. We'll check the lithium levels. And in the management beta, please remember withholding, stopping lithium would be very, very important step. Hemodialysis may be required in severe cases, especially if it is more than 4 milliequivalent per liter, then hemodialysis can be used. I hope this is clear now. Very good. So all of you remember that lithium, body treats sodium, lithium like sodium. Very good. Let's see this question. So sometimes you'll see now some miscellaneous topics that I'm discussing. During psychotherapy, therapist had developed conscious, unconscious feelings towards the patient. Irrespective of patient's mind, therapist keeps his own unmet needs towards the patient. So ये therapist की feelings है बेटा towards the patient. Tell me what is this phenomena? It is counter transference. Transference में when the patient develops feelings for the therapist, then it is transference. Very good. So the answer is it is counter transference. Answer this again. Beta, please revise Mental Health Care Act also. Again, now I'm discussing some forensic wala topics which we read in forensic also. But please revise MHCA 2017. Sometimes you may get some clinical questions also from MHCA. So the maximum duration for which a person can take admission under the MHCA, but it is initially 30 days. Usually it is for supported admission, but since this question was asked, so out of the option you can answer 30 days. Like in supported admission, first there is admission till 30 days. Later it can be extended in some other section, but at a go it is maximum for initially 30 days. Okay. Very good. But also have an idea about MHCA, very, very important. So admission we know is independent admission ho sakta hai. Supported admission is ki admission is required, is needed, but person does not have the capacity to take that decision. So then person may be help supported in the admission. So then that is admitted under supported admission. So nominated representative can take that decision. So remember two important points, beta. One is advance directive. in advance person can write their directive how they wish to be treated or not to be treated. And nominated representative में क्या है, they can nominate a person, that person can take treatment related decision for them if they don't have the capacity to take the decision. Also remember, ECT without use of muscle relaxant and anesthesia now is prohibited under this act. So whenever in India we are giving ECT, we are always giving modified ECT, that is with muscle relaxant and anesthesia. Also very important point is there is decriminalization of suicide now. So now it is presumed that anybody who has attempted suicide, he must have been under severe stress. So now there is decriminalization of suicide. So these are some important points beta which we have discussed, okay, about this. Let's discuss this question. A person killed or hurt his colleague, and on evaluation he said that he was getting instruction from voices that colleagues was about to kill him. He had disheveled appearance and disorganized speech. So somewhere they're telling you that a crime is being committed, but person may be having some psychiatric illness. So now this very important point, we talk about. So earlier it was section 84 of IPC, and now we know it is now BNS Bharatiya Nyaya Sanhita, and now it is BNS ka section 22, which embodies McNaughton's rule. Now what is McNaughton rules? It says that nothing is an offense. It will not be considered an offense if it is done by a person who at the time of doing it, if it is proven that because of reason of unsoundness of mind, he was incapable of knowing the nature of the act, कि जो act कर रहा है उसका nature he was not able to know, or that he is doing what is either wrong या it is contrary to the law. So then we will say that it will not be considered as an offense. So देखो out of the option beta what is that? Very good. So out of the option, consider not guilty due to mental illness and release him, make him undergo trial without psychiatric involvement, convict him as he is still guilty of murder, will take a psychiatry evaluation. Very important, because it says that it should be proven that during the time, at the time, because of reason of unsoundness of mind, if this is proven, then we'll say it is not an offense. So answer would be option D. Very good. Let's see this question again, but you'll see even in our videos also we talk about POXO, Protection of Children from Sexual Offences Act 2012. Now tell me the right answer here. So it is basically if sexual offense are committed on a child. So it is for a child that is under 18 years, whether it is girls, boys, or girls under 16, girls under 18. But remember, it is a gender neutral act. It is for both boys and girls. So all children under 18 years of age. So that is the right answer. Let's discuss one more question. So this question came in 2019. So again, I'm discussing this question. Sometimes you'll see some miscellaneous question, but if you see the question and see the option, you'll get to the right answer. Which of the following test is based on suspect's reaction? That is, if suspect witnesses an event, he behaves in a specific way. So what is the test beta here is being used? So again, you'll see polygraph testing. What we do is we measure physiological responses. There may be changes in the pulse rate, in the respiration, in the blood pressure, and that sometimes may help us in the identification, like a lie detector test. So then it is polygraphy that can be used. So these were the questions, but I've tried to cover some of these questions from 2019 till the last NEET PG exam, and we've got a trend. We've also seen now a lot of clinical vignettes are being asked. Also, when you're practicing MCQs, beta, don't keep any FOMO of any videos. If you know the concepts well, just try to identify what is being shown in the picture or the video if it is given, and you are able to answer it correctly. Okay? And as I always say, we are all very eagerly waiting to listen to your success story. Give your best in these coming days, in these coming weeks, and just take one day at a time. Don't think too much of the exam. Plan your day a night before. Try to give your best every day, and you'll see you'll come out with flying colors. With this, beta, thank you so much. Thank you so much. Beta, conduct disorder mein na, what is conduct disorder? See, when we talk about disruptive disorders of childhood, there is ODD and there is conduct disorder. So in ODD, child oppositional defiant disorder. Child is opposing or is disobeying. He is disobeying the authority figure like parents, teachers, but he is not indulging into any physical aggression. कोई physical aggression नहीं है बेटा. While conduct disorder में the child is violating rights of others, there is physical aggression. But please remember, physical aggression. है ना? Physical aggression है like beating others, harming property, harming animals. And remember, when we are thinking antisocial personality disorder, whenever you are making a diagnosis, the age should be 18 years or above. है ना? तो child में ऐसा behavior you can think of conduct disorder, while when you're thinking of adult, then we are thinking of antisocial personality disorder. But abreaction में क्या होता है? Abreaction may be used for management of, you know, disorders like conversion disorder, in which the person we're trying to bring to the surface, कभी कभी जो unconscious conflicts होते हैं उनको हम awareness surface पे लाते हैं with the methods like free association, hypnosis हो गया, या using some drugs, and the person also relives those emotions. कि हो सकता है कि past में कुछ memories हैं, conflicts हैं जो पर्सन अभी अनअवेयर है, और उनको जब अवेयरनेस में आता है, देर इज रिलीज ऑफ इमोशन, पर्सन रिलीव्स दोज मोमेंट, एंड दैट कैन हेल्प इन द मैनेजमेंट. In catharsis, there is simply venting out. There is venting out of the built up emotion. Okay, thank you so much beta, thank you, God bless you all, and give your best, है ना, and don't worry, just take one day at a time. All the very best, है ना, and keep the hustle on.